So hello and welcome. So today I'm just going to cover some really basics around ECG monitoring, and in particular just about single lead monitoring. I think sometimes people downplay how useful single lead monitoring can be, and I just want to talk about, first of all, how we put them on, where we put the wires, when we might change those positions, and then just go through the real basics of what we're looking at on the ECG. So typically, when we're talking about 3-lead monitoring, we have 3 leads and we have red, yellow and green, and typically we put them underneath the collarbones and round the corner like that. The green one should go on the side wall of the chest in about the 5th intercostal space, and as I say, the red one and the yellow one just go underneath the collarbones. And that is our basic monitoring position. Now, using this setup, we can actually get different views of the heart. Now, in the older days, we actually used to have to move the wires around to give us different views. But on most modern machines, there is a lead button which will allow you to change the leads. And typically, what it's set up for, and our standard view, is what's called lead 2. And lead 2 actually looks across the chest in that direction, and one of the reasons we like lead 2 is because it gives us a nice view of the ventricles, and obviously the ventricles are the bit that's pumping the blood around the body, and if we do have ischemic changes, lack of oxygen to the muscle in the heart, that's where we're going to pick them up. The other thing just to think about that is helpful to understand about the lead position is if you are looking at a particular lead, one of the leads will just basically be a reference electrode, in other words, an earth. So if we're looking at lead 2, between those 2 electrodes, well, the yellow one is now our reference electrode. So actually, our yellow electrode can go anywhere and it shouldn't affect the shape of the ECG. And why that is useful, well, again, if you're doing necklines, if you're doing anything around the top end, you then know which electrodes you can move without affecting the shape of the ECG. Okay, so that's the background and the basics of where we put the leads. So now let's just think a little bit about the actual electrophysiology of the heart. And it's important to think about because actually we need to put this in context of what's happening electrically to think about the physical ramifications on our patient. So luckily, as far as the electrical side of the heart is concerned, we can just think, in effect, we've got a top bit and a bottom bit. And the top bit, of course, is the atria, which basically just collects the blood and pumps it to the bottom part of the heart. And the bottom part of the heart is the ventricles, and that pumps it to the rest of the body. So out of the two, the bottom part is probably more important than the top part. And then you may have heard of some of the electrical parts of the heart. So basically, at the top, we've got an area of specialised cells, which is the heart's own pacemaker. So these cells beat themselves, and that's called the SA node. We've got another area down here, which is called the atrioventricular node. That crosses this gap in between. You'll notice that I've deliberately left a gap, and that's kind of electrically isolating gap between the top part and the bottom part. And there needs to be a bunch of nerves that carry that contraction across, and that's called the bundle of His. It then breaks into the left and right main branch bundles, and then we've got these little tree-like roots on the bottom, which are known as the Purkinje fibres. So let's just explain what happens with a contraction of the heart. So the heart beat is initiated at the SA node, and what happens is that just randomly contracts, and I say it's got its own inherent rate, and that gives us our P wave. We then have a little bit of a pause in between, and that allows the blood to be forced down into the ventricles before we have our next contractions. And that gap we'll refer to as a PR interval. The nerve contraction spreads across the heart, and then it arrives at the AV node. The AV node then allows it to be passed down the bundle of His, down the right and left main branch bundles, to the bottom part of the heart, where contraction is started at the bottom, spreads up, forcing the blood out. And that is represented on our ECG by a Q wave, which is a little negative deflection, an R wave, and then another negative one, which is our S wave. So that QRS complex is actually representing the contraction of the ventricles. Then again there's a little pause, and this time we get our T wave. So let me just fill those in as a Q, R, S and T wave. And T wave is just our ventricular repolarization, which is just the period of time where the heart muscle, the ventricle muscle, is just relaxing, if you want to call it that, but the nerves are sorting out, the chemicals are all rebalancing, ready for the next contraction. And so that is one heart contraction. So again, just to emphasize the important bits of the P wave, which is the ventricular contraction, the QRS, which is, the P wave, which is the atrial contraction, the QRS, which is the ventricular contraction, and the T wave, which is the ventricular repolarization. So let's just think about some of the things that we might see on the ECG, and then, excuse me. So let's just think about some of the things we might see on an ECG, and then we'll put them in context as well. So obviously we can see changes in the ECG that affect the top bit of the heart. You can actually have some changes that affect that gap in between, but I'm not going to dwell on those today. And then of course we have changes that occur at the bottom. And typically the bottom ones are the more dangerous because they're affecting the blood flow as it's being pumped out to the heart, to the rest of the body. So what type of things can we see around the atrial side? So one of the things we can see is we can see changes in our P waves. So if our P wave normally looks like that, we might get something that looks like that, or you can even sometimes get upside down things as well. And these different shapes, well, they're just a form of ectopic. So ectopic's a word we use a lot, and just as when we're referring to an ectopic pregnancy, an ectopic contraction or ectopic beat is just some electrical stimulus that started outside the normal pathway. So in this case, our ectopic beat that looks a little bit different shape, maybe that's just come from somewhere over there. But other than that, it's relatively normal. The other thing that we will look at as well is the timing of that beat. Because again, if our contraction is starting somewhere else, well, the length of time it takes to get to there is now going to be less, and that has a consequence on the PR interval. So if we see a change in the PR interval, that might tell us that there's either some type of ectopic that's causing it to be, that's causing a premature closing of that gap, or it might actually be there's some type of delay, and these are referred to heart blocks. Now again, I'm not going to go into depth about heart blocks because I think really for what we're looking at today at this really basic level, I just want to keep it really, really simple. So those are some of the atrial type things that we can see. We'll just talk a little bit about the ventricles, and then we'll just finish off, I think, just chatting about what we can look at, and rhythms where the heart's beating too slow or beating too fast. So moving on to the ventricles, in exactly the same way, we can have ectopic beats, so beats that come from outside where we normally expect them. So we could have some area of irritability down there, and we could end up with something that would look a little bit like this. So we've got our normal contraction, and then all of a sudden we've got something strange following it. So that's our normal one, and then that's clearly abnormal. A few things to notice. The first one is that see how wide the QRS is. And a wide QRS is often a giveaway that it's something happening in the ventricles. Also notice if we had a longer strip, what you might notice is that this is occurring before you'd expect it. If there was another sinus beat, another normal beat, then we'd expect it about there, but it's happened earlier. So often we refer to these as premature ventricular contractions, or just PVCs or ectopics, ventricular ectopics. Are they a problem? So typically people have the occasional ectopics, and it's not normally an issue. What we don't want is too many of them, and we definitely don't want so many of them that it starts affecting cardiac output. There is also a warning sign. So if you remember the T wave, the ventricular repolarization is a vulnerable period. And if we do get ectopics that actually occur on top of that repolarization, we refer to those as an R on T ectopic. And that is quite a worrying sign. That is a sign that potentially that patient is going to deteriorate into either ventricular tachycardia or even VF. So let's just talk about ventricular tachycardia and also VF. So what is VT? So ventricular tachycardia, if you think about it, is just basically ventricular ectopics, just linked together. And it characteristic, you get this sawtooth waveform. Notice how the amplitude is the same all the way along. There is a variant where you get altering amplitude, but again, I'm not going to worry too much about that. Is it a bad thing? Well, it's clearly not a good thing. It will reduce cardiac output, and actually, if the rate is fast enough, the patient can actually completely lose their output and go into cardiac arrest. So we would be clearly worried about VT. And then VF. So VF is a form of cardiac arrest. You will have no output at all, and now the electrical system is completely broken down, and there is no coordinated electrical activity. What's happening instead is the nerve fibres are randomly firing off all over the place. And if it's in the ventricles, if you actually view the heart, you would see it look like a kind of bag of worms. It's described as it just wobbles all over the place as the individual nerve fibres fire. Clearly, the treatment is going to be rapidly to defibrillate, and the ALS protocols in line with current thinking around your COVID patients. If this is COVID patients, what would you see on the ECG? You would see that kind of wobbliness all over the place. Completely random, uncoordinated electrical activity. The size of it can depend on, first of all, your gain settings, but also how long it's been in existence for before it's been discovered. So that starts to go through some of the basics. So the basic building block of the ECG recognition has got to be just recognising that sinus beat. And then, as I say, recognising some of the abnormalities. So as I say, to finish up, I'm just going to talk about the basic management of the patient with a slow heart rate, and then just thinking a little bit about what we're going to do with the patient with a fast heart rate. So the slow heart rate, a patient who's bradycardic, the first question is that affecting their cardiac output? If it's affecting their cardiac output, i.e. if their blood pressure is reduced, if we're talking about a patient who isn't intubated and ventilated, has their conscious level dropped out, if they're clinically being affected by this, in other words, if they're hemodynamically compromised, then the treatment of choice is going to be atropine. And atropine given and titrated up in normally around 500 milligram amounts, and basically just to try and pick up their heart rate. If it doesn't respond after the first 1 or 2 doses, that's normally a sign that there's something more insidious going on, and it's actually a patient who may need some degree of external pacing or even internal pacing eventually. Again, that's going out of the realms of what we're talking about here, but we can recognise that bradycardia. Then just thinking about the patient who is tachycardic. So clearly, depending on how fast their heart would be, beating would depend how we respond to that. It is important that we can differentiate between a sinus tachycardia, so sinus beat is the normal beat, so sinus tachycardia, which could be a response to a patient who's in pain, could be a response to a patient who's stressed, could be a response to a patient who is bleeding or requires more fluid. That management is very different from a patient who's got some type of cardiac arrhythmia that's causing a fast heartbeat. Now again, if you're unsure about ECGs, it's not that important to recognise what the underlying rhythm is, other than to recognise that that is abnormal and you need more assistance. The management of tachyarrhythmia, so fast heartbeats, is quite confusing. There is a slightly horrendous algorithm that supports it, but basically the questions you're going to ask is fourfold. So it starts off with, the first question is, are there any adverse features? And the adverse features you're looking for is a patient who's got some degree of shock, who's got chest pain, heart failure, or their conscious level is dropping off. And if the answer to that is yes, then this is probably a patient who we will be considering DC cardioversion for. If the answer is no, then the treatment depends on whether the underlying rhythm is broad complex. Remembering broad complex typically, not always, but typically suggests that the arrhythmia is coming from the ventricles, or a narrow complex and where it's coming from the atria. And in both cases, whether it's broad or narrow, we ask the third question, which is it regular or irregular? Basically, if it's regular and narrow complex, then we're probably talking about something like an SVT, and we may try some vagal manoeuvres and use other drugs like adenosine. If it's an irregular one, we maybe look at something like AF, and in which case there are treatment protocols to follow, particularly depending on how long this AF has been in existence for. If it's a broad complex arrhythmia, if it's regular, then we're thinking obviously around VT most of the time. There is an exception, but again, I'm not going to dwell too far. And if it's irregular, then this is something more bizarre. And again, that's another time we'll be getting expert help. I just wanted to cover the basics though, because I say there is an awful lot you can understand from a simple 3-lead ECG. Really understanding what is normal to start with is important, and emphasising again that actually the position of the electrodes is quite fundamental to what you see on your ECG monitor as well. Okay, I hope that was useful, and look after yourselves.